Let's start off with the history, and that's, again, everything. Back to day one in here, conscious assessment, get a history on somebody, what happened. So we're going to go through the questions. How did the injury occur or start? Was the onset gradual or immediate? That's a big hammer, little hammer injury. Exactly, where is the pain located? And I'll have the athlete, take one finger and point to me where it hurts the most. So I can, it kind of tells me right away what structure we're referring to. Have you ever injured your foot before? Have you started or changed your training program? So newbies have a tendency to have new types of injuries. People change up their training surfaces, which leads to the next question: which type of surface or terrain is used for your training? What type of footwear are you using? Real flexible stuff like a wrestling shoe will bring up different types of injuries than perhaps a basketball shoe. Did you hear any noises or sounds, snap, crackle, pops, things like that? All right, so that's getting your history. And I'm going to ask you, get a history. Or I may say, please ask 4 questions from the list of many for getting a history. So that'd be like 4 points, all right? Then we're going into observation. First thing out of your mouth, you should say, I'm going to observe bilaterally. You want to compare the good to the bad, so you know what is normal for that person. And then we're going to watch them functionally. How do they walk? How are they, can they jog? Can they do their sport-specific activity? Back up to bilateral comparison. I will say, what exactly are you looking for? And you're going to say, I'm looking for swelling, deformity, discoloration, blisters, or calluses. All right? Now, palpation, that's not heart. Okay, we're looking at orthopedics right here. We're going to be touching. So we're going to be looking at the areas, and you need to know where the calcaneus is, and we know where that is. That's the heel bone. Everybody should know where that's at. The metatarsals, that's the long bones right through here, and you're going to palpate through those. I'm going to ask you, I won't have you palpate everything, but probably at least 2 to 3 of the items I'm going to say, locate the calcaneus, locate the metatarsals. You want to palpate through those. The phalanges are the toes. The plantar fascia, if you remember, and inserts down here at the calcaneus, and this is going to tickle, and it comes right up. It's this large piece of fascia that comes up and that provides that arch support. So you'll palpate through there, and you really want to get into that heel, because sometimes they'll get a heel spur, and it'll be right at the attachment of the plantar fascia. Other places you want to palpate, you get the tibia and the fibula. So here's this big bone right here, the nice meaty bone. 95% of the body weight of the body is right on this bone. Then you got your fibula, which we go right up the side here, and you're going to palpate up the side. And what is this knob right here? The lateral malleolus. All right, so you need to know what that is. And then the tibia comes down and sits on top of the talus. And what's this little knob right here? Medial malleolus. So those are key marks to help you figure out where the other structures are, in particular the lateral and medial ligaments. So we're going to go with, let's look at, so that was the bony tissue. And usually we always observe bony tissue, or palpate bony tissue first. Now we got soft tissue, gastrocnemius, okay? And then you got the Achilles tendon. So the gastrocnemius, basically is this large muscle here, the belly of the muscle, and you want to make sure you know where that is. And it comes down and narrows down into a tendinous tissue called the Achilles tendon. It comes all the way down and inserts in here in the calcaneus. All right. Now you have the lateral muscles, and this is lateral. So here's our fibula and muscle, so it's soft tissue. If you're palpating right here on the fibula, I'm going to go, that's the fibula, that's a bone. We want you in the soft tissue. So here, along here, you can feel the perineal muscles. And they come all the way up to the knee. So you got to get up into that knee. Okay, and you'll feel this little nodule right here. Gertie's tubercle. Okay, and she's going to come on down, all the way down. And there are 3 perineal muscles. I just want you to collectively get the group through here. All right, just collectively get the group. They insert at different areas. One is the base of the 5th metatarsal, which you know where that's at, and then their other spots go underneath the foot, the arch. So sometimes if somebody gets an ankle sprain, they'll get the perineal tendons, and they'll say, yeah, but my foot's cramping up. Well, you probably got that perineal tendon and it's cramping up. Okay, not uncommon. So perineal muscle group. Anterior muscles, so here we go again. I want to palpate, that's bone, right? So I want to get the anterior muscle right here, anterior tibialis, it's right through here, palpating. Again, you can feel it. It's just a soft tissue, all right? That's hard, that's soft. Know the difference. Then we have the deltoid ligament. Deltoid is the medial ligament. And we know where the medial malleolus is, right? And it's pretty much right in this area, shaped like a deltoid, right in that area. And you want to palpate through that region. Now we got to get the other side. What is more common, lateral ankle sprains or medial ankle sprains? Lateral. You just had the test on it. Good. Okay, so here we go. This is where they're going to get hit most. And you can kind of palpate. See, it opens up. There's a nice little gap in there. Relax for me. Okay, so here we have, this pretty much is approximately the anterior talofib, post-tib, fib-tib, and the posterior tibiofibular ligament. Okay, so we've got anterior talofib, tib-cal, tib-cal, no, cal-tib. Oh my God, no it's not. Calcaneofibular ligament. I'm sorry. See, I have a little brain fart right there. Because it's the calcaneus and the fibula, right? Right, sorry. And you're like, Haney, you know, you just had a test on it, though, didn't you? And then we have the posterior talofib. All right, sorry. So you want to palpate through there, and I'll probably edit the snot out of that. And so we want to palpate through there, okay? And that's what we're referring to. I will have you probably palpate them separately, because they are very distinct ligaments, distinct areas, all right? Special tests, that would be next. So you've got active range of motion, resistive range of motion, and passive range of motion. Active range of motion is what she does, right? On her own muscle power. So I'm going to go with dorsiflexion, and because she's a patient and she doesn't know the medical terms, I'm going to tell her, bring your nose, toes to your nose. Okay, and I would look at Mrs. Haney and say, this is dorsiflexion. And plantar flexion, plant the toe down into the ground. Plantar flexion, right? Okay, relax. Okay, and this next up would be she's moving it, inversion, right? And then out this way, eversion. Got that? So nose up. What's that? Dorsiflexion.
Inversion, eversion.
Okay, so I'm seeing how she moves on her own power. Next up would be resistive. So she's going to pull up toward right here. Resistive dorsiflexion, resistive plantar flexion, resistive inversion, resistive eversion. Okay? So same directions. I'm just giving her resistance there. Last up, she's going to relax, and I'm going to move her in the movements. Got it? Passive is my power. Anterior drawer test, it's like I'm opening a drawer. You open a drawer, you pull things anteriorly, you pull them front towards you. So I'm going to pretty much grab hold of her tibia. I'm going to grab hold of the calcaneus, and I'm going to open. Here's my arm's going to be doing this movement. Okay, let's hope not too much, because then you'd have anterior drawer test. And then I'll ask you, what ligament are you testing for? Okay, see how I'm going to rephrase it? Same question, just a different way of phrasing it. Taylor tilt, what test, I may ask you, please demonstrate for me a test that will test the medial ligaments and the lateral ligaments of the ankle. You would say Taylor tilt, and you would demonstrate the Taylor tilt. See how I'm phrasing things? Okay, Thompson test, we'll do that last. Heel tap and squeeze test. I may ask you, please demonstrate for me one of the two tests that you would do to determine bone integrity or bone stability or fracture. You know what I'm saying? I may phrase it like that. And the two tests are the heel tap and the squeeze test. So as if you recall, heel tap, I'm going to basically get a running start. I'm not going to get a running start, but I'm going to take my heel of my hand and I'm tapping it up. Okay, in fact, I probably don't even need it. I'm going to tap it up like that. That is doing what? Remember? Sending vibrations up through there, and if there's any disruption or the bone integrity is damaged, they'll know it. Now, sometimes just from swelling, though, that vibrations go through swelling, and with your ankle, I'm sure if I did that to your ankle, you would not be very happy with me. So is it 100% guaranteed? No, it's not. Understand that. It's not, but it gives us some information. I mean, that shouldn't have bothered you what I did. I mean, so like, what the heck's you doing? Well, like awkward, getting your heel whacked. But for the most part, that's what you need to do. Then we have the squeeze test. Squeeze test. I'm assuming that we got some damage down in the ankle. I'm going to come up here and I'm going to push together these two bones. And when I push them together, these ends are going to bow out, right? Well, they'll bow out if there's instability or a possible fracture. She's going to feel that. I will feel stuff up here if there's instability or fracture down here. You feel things. You feel crepitus, which is a noise. You'll feel popping, snapping. I've had situations where we've done this here, and they felt they had a fracture up here. And we were able to determine that because we went like this. They're like, ah, and you could do it in the arms. I mean, you could do it, I mean, wherever there's bone, if you do this compression, again, not on top of the part that is injured. The key with the squeeze test is you're doing it away from the area that's hurt. Understand that. All right, so now we have, so we'll go functional test, and you'd have her walk, jog, run, see what she can do functionally. Last test is the Achilles test. And this is to, again, we talked a tiny bit about the Achilles tendon rupture. Very unusual to happen in your age group. Men over 40, they're candidates. They have a tendency to pop out these muscles. And again, it's like they said, oh, I feel like I got hit in the back of the leg with a racquetball or somebody kicked me. And it just snaps and it rolls right up. So if you notice when I squeeze her calf muscle, just want to relax. She got a little pump bump going on there. What do you see her foot doing? It's kind of going into plantar flexion a little bit. Okay, that's because I'm triggering the calf muscle here. So what I'm looking at is that I'm getting movement. If this was ruptured, like 100% ruptured, I would not. I would just first of all, it's not rocket science. Let's see somebody with a ruptured calf muscle. It's pretty obvious. It rolls right up, and it's a big ball up here, and there's a big dent down here. But you would just go ahead, check for integrity. Some movement, no movement. It would give you an idea if it is completely ruptured. Alrighty? Any questions on that? Let's hope that took with video. So let's, you can pause.